Welcome back to the Nurses Study Partner. This is GORD, also written GERD, Part 1, The Foundations, in 10 in-depth scenarios. We'll cover why reflux happens at the lower esophageal sphincter, the typical and atypical symptoms, why new chest pain must first be checked for a cardiac cause, the risk factors, the alarm features that need endoscopy, how we diagnose it, and first-line care, lifestyle, antacids and alginates, and proton pump inhibitors. Read each case, weigh all four options, pause to choose, then check your reasoning. Let's begin. Question 1. A student nurse asks why acid, which normally sits safely in the stomach, ends up burning the esophagus in reflux disease. She wants the core mechanism. Which best explains gastroesophageal reflux disease? Option A. The stomach suddenly stops producing any acid at all. Option B. The esophagus makes its own acid and burns itself. Option C. A weak or relaxing lower esophageal sphincter lets acid up. Option D. The small bowel pushes food upward against gravity. Pause here and choose your answer. The answer is C. A weak or relaxing lower esophageal sphincter lets acid up. GORD is caused by an incompetent lower esophageal sphincter, especially frequent transient relaxations and reduced resting tone, which lets acidic stomach contents reflux upward into the esophagus. Unlike the stomach, the esophageal lining is not built to resist acid, so it becomes inflamed and painful. The esophagus does not make acid, and the bowel does not push food up. Question 2. A 45-year-old man describes a burning feeling behind his breastbone that rises toward his throat, with a sour, acidic taste in his mouth. It is worse after large meals, when he bends over, and when he lies down at night. Which best describes these classic symptoms? Option A. Right-sided colicky pain typical of gallstone disease. Option B. Heartburn and acid regurgitation typical of GORD. Option C. Crushing central pain radiating to the left arm only. Option D. Lower abdominal cramping relieved by opening bowels. Pause here and choose your answer. The answer is B. Heartburn and acid regurgitation, which are typical of GORD. The two classic symptoms are heartburn, retrosternal burning that rises toward the throat, and acid regurgitation, a sour taste. They are characteristically worse after meals, on bending, and lying down when gravity no longer keeps the acid down. This is not gallstone colic, cardiac pain, or a lower bowel problem. Question 3. A patient reports burning chest discomfort he is sure is just his reflux. It came on today, is heavier than usual, radiates to the jaw and left arm, and comes with sweating and breathlessness at rest. What is the most appropriate nursing action? Option A. Treat as possible cardiac pain. Urgent assessment first. Option B. Reassure him it is only reflux and give an antacid. Option C. Advise him to lie flat and sleep the discomfort off. Option D. Tell him to eat a large meal to soak up the acid. Pause here and choose your answer. The answer is A. Treat it as possible cardiac pain and arrange urgent assessments first. Although GORD can cause non-cardiac chest pain, this presentation, new, heavier pain radiating to the jaw and left arm with sweating and breathlessness at rest, could be cardiac, an acute coronary syndrome. The safe rule is to exclude a cardiac cause first with urgent assessments and ECG and observations before blaming reflux. Reassurance, lying flat or eating would be unsafe if this is a heart attack. Question 4. A community nurse reviews a patient whose reflux has worsened. He is overweight, smokes, drinks alcohol and coffee, eats large fatty meals late at night, and often lies down straight afterward. Which statement about his risk factors is correct? Option A. His excess weight has no bearing on reflux at all. Option B. Only tablets, not lifestyle, can ever help his reflux. Option C. Reflux is purely genetic and cannot be influenced. Option D. His weight, smoking, and late meals all worsen reflux. Pause here and choose your answer. The answer is D. His weight, smoking, and late meals all worsen reflux. GORD is strongly influenced by modifiable factors: obesity, which raises intra-abdominal pressure; smoking and alcohol, which lower LOS tone; fatty or large meals; caffeine, chocolate and peppermint; eating late and lying down after meals. Hiatus hernia and pregnancy also contribute. Because most are modifiable, lifestyle change is central to treatment, so reflux is neither purely genetic nor unrelated to habits. Question 5. A patient has a chronic dry cough, a hoarse voice worse in the mornings, and wheeze not responding to asthma inhalers. She has occasional heartburn but no obvious lung disease on examination. Which explanation should the nurse consider? Option A. These symptoms can never be linked to acid reflux. Option B. This is certainly lung cancer until proven otherwise. Option C. Extraesophageal GORD can cause cough and hoarseness. Option D. Hoarseness always means a simple viral throat infection. Pause here and choose your answer. The answer is C. Extraesophageal GORD can cause cough and hoarseness. GORD has atypical features: chronic cough, hoarseness and laryngitis, asthma-like wheeze, dental erosion, globus and non-cardiac chest pain from acid irritating the larynx and airway. These can occur with little or no heartburn, so reflux should be considered when such symptoms are persistent and unexplained. It is not true that these are never reflux related, always cancer, or always a viral throat. Question 6. A 58-year-old with long-standing reflux now reports difficulty swallowing solids, unintentional weight loss, and one episode of vomiting dark altered blood. He looks pale. How should a nurse interpret and act on this? Option A. Alarm features. Refer for urgent upper endoscopy. Option B. Normal progression of reflux. Simply increase antacids. Option C. A minor throat problem. Reassure and review in a year. Option D. Expected aging changes. No investigation is needed. Pause here and choose your answer. The answer is A. These are alarm features needing urgent upper endoscopy. Dysphagia, unintentional weight loss, GI bleeding, and anemia, especially with new symptoms over about age 55, are alarm or red flag features. They require urgent upper endoscopy to exclude an esophageal stricture or cancer and other serious disease. These are not a normal progression of reflux, a minor throat issue, or simple aging. Question 7. A 40-year-old with typical heartburn and regurgitation and no alarm features is seen in clinic. Which approach to diagnosis and initial management is most appropriate? Option A. Immediate surgery without any trial of medication. Option B. A barium enema of the large bowel to find the cause. Option C. Lifelong antibiotics started on the day of diagnosis. Option D. Clinical diagnosis plus a trial of a PPI. Scope if it fails. Pause here and choose your answer. The answer is D. A clinical diagnosis plus a trial of a PPI with a scope if it fails. For typical symptoms without alarm features, GORD is usually a clinical diagnosis, and a trial of a proton pump inhibitor is both diagnostic and therapeutic. Upper endoscopy is reserved for alarm features, refractory or atypical cases, and 24-hour pH monitoring with manometry is the gold standard when the diagnosis is unclear. Surgery, a bowel barium enema, or antibiotics are not the initial approach. Question 8. A patient with mild reflux wants to know what he can change himself before relying only on medicines. He is overweight, eats late, and sleeps flat. Which lifestyle advice is most appropriate? Option A. Eat large meals right before bed to line the stomach. Option B. Lose weight, raise the bed head, avoid late or large meals. Option C. Lie down flat immediately after every single meal. Option D. Increase smoking and coffee to help settle the stomach. Pause here and choose your answer. The answer is B. Lose weight, raise the bed head, and avoid late or large meals. First line lifestyle measures for GORD include weight loss, raising the head of the bed, avoiding large or late meals, leaving about 3 hours before lying down, avoiding trigger foods like fatty and spicy food, caffeine, chocolate, and alcohol, and stopping smoking. These reduce reflux and often improve symptoms markedly. Eating before bed, lying flat after meals, or more smoking and coffee would all worsen reflux. Question 9. A patient has occasional mild heartburn a few times a month, mainly after heavy meals, with no alarm features. He wants something for quick as needed relief. Which is the most appropriate first option? Option A high dose proton pump inhibitor taken indefinitely. Option B, urgent surgery to tighten the esophageal sphincter. Option C, antacids or an alginate for quick as needed relief. Option D, a course of 2 antibiotics to clear the symptoms. Pause here and choose your answer. The answer is C, antacids or an alginate for quick as needed relief. For mild infrequent reflux, antacids, which neutralize acid, and alginates, such as Gaviscon, which form a protective raft on the stomach contents, give rapid as needed relief and are a sensible first step alongside lifestyle change. A PPI is stepped up to for frequent or troublesome and erosive disease. Surgery and antibiotics are not appropriate for mild intermittent symptoms. Question 10. A patient has frequent, troublesome heartburn most days that limits his sleep and work, and endoscopy has shown inflammation of the lower esophagus. Which is the most appropriate first line medication? Option A proton pump inhibitor such as omeprazole as first line. Option B, only an occasional antacid, whatever the severity. Option C, a strong opioid painkiller taken regularly for the pain. Option D, no treatment at all. Troublesome reflux never needs drugs. Pause here and choose your answer. The answer is a proton pump inhibitor such as omeprazole as first line. For frequent, troublesome, or erosive GORD with proven esophagitis, a PPI is first line. It strongly suppresses acid, relieves symptoms, and heals the esophagitis, usually given for 4 to 8 weeks, then reviewed. H2 blockers are an alternative or add on. An antacid alone is insufficient here. Opioids are inappropriate, and troublesome reflux does need treatment. Let's recap GORD Part 1. Reflux happens when a weak or relaxing lower esophageal sphincter lets acid climb into the esophagus. The typical symptoms are heartburn and acid regurgitation, worse lying down and after meals. New severe chest pain must first be checked for a cardiac cause. Triggers include obesity, smoking, alcohol, and late meals. Atypical features include chronic cough, hoarseness, and asthma like wheeze. Alarm features, dysphagia, weight loss, and bleeding need urgent endoscopy. For typical symptoms without alarm features, a PPI trial is used with a scope if it fails. Lifestyle measures include losing weight, raising the head of the bed, and timing meals. Mild reflux is treated with antacids or alginates, and frequent or erosive disease with a PPI first line. Keep going, and remember, we don't pass alone, we pass together.